Today, some cancers can be cured even after they spread. The new approach that's offering hope in the later stages of the disease. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. If you catch cancer early before it spreads, the odds of survival go way up. And vice versa. Once cancer has spread and it's metastatic, it's typically considered incurable. But today we are exploring a middle ground. When cancer has spread but is still considered potentially curable, or at least able to be kept under good control for long periods of time. Helping explain that middle ground today is Dr. Krishna Reddy, a radiation oncologist at the University of Kansas Cancer Center. Good morning to you.
Good morning, Jess. Thank you.
Good to have you with us today. Also with us today, we're hearing from Chester Fitch, who has been living with prostate cancer for more than a decade now. Chester, how are you this morning?
Good, very good. Thank you.
Good to have you with us. We're anxious to learn more about your story, and we just appreciate you being here with us. And before we jump into that story, we do need to talk measles now. The state of Kansas reported its first measles case since 2018. It's in Stevens County in the southwest corner of the state. People who may have been exposed have been notified. Health officials don't know if this is linked to other measles outbreaks in the U.S., but let's talk more with Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control at the University of Kansas Health System. Hawk, this is one single case in Kansas, and there isn't a lot of available information. What do we know and what don't we know?
Yeah, just again, like you said, just very little information as far as age or other community or demographics, but we will keep watching. Hopefully there will be more information out as we go forward in this. Unfortunately, we do know that vaccination rates have been low, and I think we have some information about that.
So looking at kindergarten MMR vaccination rates over the past 10 years, Missouri's rate has dropped nearly 6%, while the rate in Kansas has actually gone up a bit, but they're both below the national average. What is the goal for herd immunity? It's at 95%?
Yeah, it's about 95%. And why is that? Is because if you have 95% of the people who are vaccinated, who are protected, they can essentially stop the spread to that small percentage that may be unvaccinated for one reason or another. Unfortunately, what you have shown there on the screen, Jessica, what you're talking about, is those numbers for vaccination rates are very low. So we maybe should expect, especially if there's other communities that are, more or less vaccinated compared to the whole state. If measles gets into those less vaccinated communities, we can expect to see more. Hopefully there will be no more identified cases in Kansas, because we don't want people to suffer unnecessarily from something that is so easily protected against with these vaccines, but we will just have to wait and see.
Hawk, there are still two pretty large outbreaks in Texas and New Mexico, which unfortunately include 2 deaths at this point. What is the latest there?
Yeah, so the latest is over actually 250 cases in the Texas-New Mexico one. Over 36 hospitalizations, 2 deaths. Again, the hospitalization rate is a little bit lower than we typically see. We typically say 1 in 5 are hospitalized. We're running about 13-14%. But, again, if we can have less people in the hospital, that's always good, but we have to wait to see the numbers and how they play out. Unfortunately, there have been 2 deaths. Typically, we see about 1 death in 1,000, but right now, so far, we've already seen 2 deaths. Again, this is just tragic. It's a horrible tragedy, something that could be prevented with vaccination. Hopefully, new numbers will come out today. Hopefully we can start to see a decrease in the numbers of that population that has been infected, hospitalized, and of course die. But I think for right now we are still considering that the outbreak is still ongoing in a strong pace.
There was a headline last week about a measles exposure of a traveler out of LAX, the main airport in Los Angeles. If someone is about to take a trip for spring break, do they need to be doing anything in particular right now to protect themselves from measles?
Yeah, I mean, certainly they should know and understand if they have been vaccinated or if they are protected. Obviously, for children, they are less likely to know. It is really up to those parents, those decision makers, to know and understand if their child has been vaccinated. If you are older and you may not, you are able to make your own decisions, and you don't have a vaccination record per se or can't find it, talk with your medical health professional. You can discuss with them, see if you can at least get some vaccination record. Sometimes we can also check measles titers to look for immunity. And again, if there is really any question, the best thing is to get a dose of vaccine. However, there are unintended consequences with that as well. We know that there has been some sort of vaccine shortage in that West Texas area because there is a demand for it now. So we have to be wary of that. I think it's just best to know and see if you have been vaccinated. If you have received 2 doses of MMR vaccine, you are considered protected at this point in time.
And I know you're looking forward to our Open Mics with Dr. Stites episode coming up in late April when vaccine expert Dr. Gregory Polin from Mayo Clinic and an infectious disease expert from Children's Mercy, they will join you both to go much more in depth about measles, right?
Oh, absolutely. You know, talking with Dr. Polin, always so knowledgeable and so helpful, and I think our audience really enjoys them. There's going to be a lot of good information in there. And again, we are just looking to help protect individuals, families, the community, everyone around us as well. So it's going to be a good show and have a lot of good information.
Great to talk to you this morning.
Thank you.
Thanks so much. Turning back to our topic of cancer that has spread but is still treatable. Dr. Reddy, let's start with the basics. Cancer has stages. Stage 4 usually means that the cancer has spread, it's metastatic, that it cannot be cured. But teach us about, I'm calling it the O word, a very long word. I'm going to let you pronounce it to get us started. I'm learning about it. Tell us about it.
Sure. So oligometastatic cancer is basically cancer where it has spread, but that is limited to just a few sites. So typically that's thought of as being spread to 1 to 5 sites. And this is still a very novel concept. It's very cutting edge. It's controversial. And there's a lot of clinical trials that are going on around the country in different types of cancer that are looking at treatment of oligometastatic disease. But we think of oligometastatic disease as maybe existing on a spectrum between somebody who has just localized cancer and then someone who has more widely metastatic cancer. So this is kind of an in-between or middle ground where, again, it's spread but only limited to a few sites. So while the traditional paradigm of treating metastatic cancer with systemic treatment still very much is true for oligometastatic cancer, we consider more locally aggressive therapies like stereotactic radiation treatment or even sometimes surgery as also potentially being employed in the treatment of these patients.
What types of cancers are most commonly oligometastatic?
Yeah, so right now there's really 4 main types where we believe this state exists and where a lot of clinical trials are being done. That's prostate cancer, renal cell carcinoma, lung cancer, and colorectal cancer. So a couple of the big cancers.
Chester, your first cancer diagnosis was back in 2010. You had your prostate taken out. After that, did you believe that the cancer was behind you? How did you approach life after the treatment?
Yeah, good morning, both of you. I had my prostate out actually 14 years ago today. And I thought that it was, I was done and everything was going to be fine.
So how long were you cancer-free before learning that the disease had then returned?
Just about a year, I think. And then the PSA started to go up and obviously there was something array. So, yeah.
So that's what led to the discovery of the new metastases. You were just getting a checkup and noticed that the PSA went up? Or were there other symptoms?
No, I never really, excuse me, I never really have had any symptoms with the cancer itself, I don't believe. But it's always been the PSA going up that, has notified everybody that there needs to be something more done.
So when did you hear this word oligometastatic? How did the doctor explain that word to you and what it meant for you?
Well, I'm not sure. I probably have heard that word. Excuse me. But I don't really recall. And I mean, I think I always am interested in learning new words, but at this point, I was more concerned about what my treatments were going to be, and how it was going to be done. So I'm not sure exactly when I heard it, but I know I have.
But it makes sense. You wanted to know how it was going to affect your treatment and what it meant for you treatment-wise. Dr. Reddy, traditionally metastatic cancer has been considered incurable. How has our understanding of oligometastatic disease changed that perspective?
Yeah, so I think that the idea of oligometastatic disease as maybe being a middle ground where cancer is spread but can be still treated aggressively and potentially curable has really kind of challenged that paradigm. And I think that this comes to the idea that there are folks we understand where biologically their cancer, even though it's spread, might be able to be completely controlled, even to where we don't see it on scans for many, 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 many years. And I think that that pretty much approximates a cure for many patients in the sense of not being able to really see cancer or have any evidence of cancer and allow folks to live a healthy, active life, taking care of their families, working, doing everything that they do. So what really has changed is the idea that biologically not all folks with metastatic cancer are the same. And you might have some folks that have metastatic cancer, and when it's confined to just a few sites, by being more locally aggressive in treating those sites, you can sometimes hopefully keep the cancer under control, and that might prevent it showing up in new sites.
So in Chester's case, you treated him with a form of radiation called SBRT. Can you explain what that is? Why was Chester a good candidate for this?
Sure. Well, when Chester's PSA was rising, we obtained a PSMA PET-CT, which is basically a PET-CT showing where his rising PSA is coming from, where exactly the cancer is. It localized the cancer to being shown in only one spot, and that was in his left clavicle. And so we treated that area with this targeted radiation treatment, and stereotactic body radiation treatment, or SBRT for short, is just very targeted, ablative intent radiation treatment. So a high dose radiation treatment given in a very, very targeted, precise way in just a few treatments. And in Chester's case, that was just 3 treatments, each about 20 minutes. And all as an outpatient with essentially no side effects, but really gives a dose that can hopefully ablate or destroy the cancer at that location and do it in a very safe way.
And you brought some scans showing Chester's before and after.
Yeah.
Let us see those and show us what we're looking at.
Sure. So this is a kind of a cross-sectional view of Chester, and this is the arrow is pointing at kind of the left clavicle where it meets the humerus. So basically in the left shoulder, that lateral left clavicle, where that red spot is, that's where that hypermetabolic focus is of where the cancer was that was lighting up on the PET scan. And so in the before image, that's basically what that PET-CT showed. We treated Chester with this targeted radiation with SBRT to this site. And you can see in the after photo, essentially minimal uptake there, basically showing a great metabolic response of the cancer to this targeted radiation treatment. And that correlated very nicely with Chester's PSA coming way back down under control.
So how do you balance, Dr. Reddy, the goal of extending survival with maintaining a good quality of life for your patients?
Yeah, that's such a great question, Jess. I mean, that's really everything. I think we as cancer providers in the multidisciplinary team are always thinking about that. And I think that we know that systemic treatments like chemotherapy and immunotherapy and all of the targeted therapies we have now play an important role in keeping cancer under control. But where local treatments like SBRT come in is that because they are so well tolerated with minimal side effects and do a great job controlling cancer where it is, when a patient has limited metastatic disease, we think that we can employ these treatments, and sometimes that can even allow patients to have a break from systemic treatment, which is very important from a quality of life standpoint because it allows them to have time off of the side effects of systemic treatment. In addition, if a patient's tolerating systemic treatment well and they develop a few new sites of metastatic disease that maybe aren't controlled on their current systemic treatment, we can use SBRT, as I say, to kind of get rid of the spots that aren't behaving. And by doing that, we can get the cancer back under control so they can stay on the treatment that they're on and not have to be escalated to another systemic treatment that may have more side effects.
So, Chester, tell us about your experience with this radiation treatment.
Yeah, it was great. I mean, very not invasive at all. You know, here lately, I just went in for spots on my spine, and it was 2 spots on my spine actually, and each one they did them together, and so it was 3 days and about 15 or 20 minutes per day, and that was it, and very, very little side effects. I had a little bit of a sore back for a little bit, but really nothing to complain about at all.
Well, be sure to ask your questions. You can use the chat on YouTube or Facebook. You can email the Medical News Network. That information is there on your screen. Chester, you've been through a lot of different treatments and cancers, and we've been talking a lot about radiation. What did you do before that in years past?
Dr. Parikh and Jennifer Hines really did a great job of kind of keeping me going with the cancer. I think the medication there was abiraterone, and took that. I'm still taking that, actually. Abiraterone, I should say. But they've done a great job. And then, of course, you know, with Dr. Reddy, he's doing an excellent job of keeping me going here.
What has surprised you, Chester, about this experience, just emotionally? You've been going through this for many years now. You stayed positive, it sounds, but how have you managed?
Well, I'll tell you what, I have a wonderful support team. My wife is fantastic. Friends and family, as my son there with his nice dog. There's my wife and my son both, and there we are. Yeah, and I don't know, we enjoy walking. We, you know, on nice days, we'll walk, you know, 5 or 6 miles a day, and we just enjoy life. And you know, I'm glad to still be here.
Well, and you're expecting a grandchild soon, right?
That's right. Any day, really.
You've got to be around to hang out with that grandkid.
Darn right. That's
Darn right. And I have to show this picture because you are quite an impressive tomato gardener. I mean, this was worth showing because I'm sorry, I'm quite impressed and I'm quite envious of this. But you grow these tomatoes, and this must be kind of a bright spot in your life.
It is. I love doing it. It's what I look forward to every year. And I mean, you know, you can't wait till winter gets over so I can get out and start going.
Right? Don't we all? It really is.
Yeah. But it's fun to do, and the tomatoes are pretty good.
I was going to say, you can make some really good BLTs out of those.
Yeah, oh yeah, that's right.
Well,
and they're
nice.
Great on the hamburgers.
I bet, Dr. Reddy. It's nice, though, to know that your patients that they're out living life. Yeah. They've got a great support system behind them. That makes a big difference, doesn't it?
That's everything, absolutely.
Because you can only take them so far, but when you send them home, you know, they've got to keep their spirit going.
That's right.
Chester, question for you though, because we've talked about how you've been going through this for so many years. Oftentimes there's a stigma when it comes to prostate health and, you know, prostate cancer. Have you found yourself over the years talking to your friends about it or answering questions about prostate health? And if so, what have those conversations been like? You have sons. Yeah,
absolutely. And you know, believe me, I want to tell people that a cancer diagnosis, especially prostate, because I know, is not end of life. It is, you know, it may not be, in most cases anyway. I mean, it's not probably curable, but it is, you know, livable. That's, and I think people should know that, you know, and with all cancers, really.
Is there anything you wish you would have known earlier in this cancer journey, thinking back on it?
Yeah, I wish I would have gone in sooner and had it removed sooner, so that it may not have come back at all.
But that's why you're on today. Someone's going to hear your story and learn from it. So we appreciate you sharing all that. Dr. Reddy, how
You
has the
bet.
role of precision medicine, like we're talking about today, targeted therapy and immunotherapy, evolved in treatment of oligometastatic cancer?
Yeah.
Why does this matter?
Well, that's a great question. I think that the role of local therapies like SBRT have only increased in the setting of our better systemic treatments. So now that we have a lot of systemic treatments for cancer, in addition to traditional chemotherapy, like immunotherapy, like targeted therapies, and very precise molecular therapies, these kinds of agents we're always looking to try and keep patients on as long as possible. So, for instance, if a patient has a particular genetic driver for lung cancer, let's say, and they're on a targeted therapy, we really want them to be able to be on those therapies as long as possible, because usually they work very well and are much better tolerated than traditional chemotherapy. And so when that's the case, and when patients have, again, isolated areas of cancer maybe that aren't under control, it really allows an opportunity for us to use our locally aggressive treatments like radiation treatment and SBRT to basically control those areas that aren't under good control.
So what else do you take into consideration when you're approaching a treatment plan for a patient when it comes to oligometastatic cancer?
Yeah, it's really a multidisciplinary effort, and I think that's really the right way to fight cancer, and we do such a good job of that here at KU with our medical oncologists, our surgical oncologists, all specialties in addition to radiation oncology, and we work really closely together. We discuss patients in a multidisciplinary tumor board and really decide, because there's no cookie cutter approach. There's really no textbook when you talk about patients that have metastatic disease, especially when they have limited burden metastatic disease, and there's no real consensus. And this is where there are a lot of ongoing clinical trials, but for patients that are dealing with this right now, we as the multidisciplinary team have to really figure out together what's the best approach for this patient. And in Chester's case, Dr. Parikh and we've had a whole wonderful team, and we've worked very closely together, deciding at each step, at each scan, okay, is this a good time for local treatment? What should we do from a systemic treatment standpoint? Really putting together all of our approaches.
Well, my next question was, what does it mean for the Cancer Center to have a dedicated oligometastatic cancer program? And I think you just answered it very,
That's
very
right.
well.
It's just putting additional focus on this and making sure we're leveraging all of the different kinds of treatments we have in our collaboration as a team to really do the best job we can for these patients.
We talked about patients and caregivers and family. What should patients and their caregivers know about advocating for the latest treatments and options that you've been mentioning this morning?
Yeah, I think it's just important for patients to know, exactly as Chester said, that even a diagnosis of metastatic cancer is not the end of life. It's really just important for them to ask questions about what treatment options are available, and even if their cancer is oligometastatic, and be able to meet with all of the different care providers that help fight cancer, including medical oncology, surgical oncology, radiation oncology. I always encourage patients to get a second opinion, and definitely here at KU with our comprehensive cancer center, we have all of the latest treatments. We also have a lot of clinical trials, and I think that's also very important for patients to be informed about.
Let's get to some questions from our viewers this morning. Amy wants to know, how does an oncologist determine whether a patient has oligometastatic disease rather than a more advanced stage?
Yeah, so oligometastatic disease is really, again, limited to just a few sites. And so really it's our latest imaging technologies that allow us to diagnose someone as oligometastatic. In Chester's case, we have PSMA PET CTs, which are basically utilize a radio tracer that specifically highlights something that only prostate cancer cells express. So we're able to really find prostate cancer anywhere where it is in the body. But for different kinds of cancers, we have different imaging modalities that really allow us to see cancer when it's still at a very low level.
Stuart wants to know, is this a new idea? Why weren't patients in the past treated for oligometastatic disease?
Yeah, well, oligometastatic disease has been around for as long as metastatic cancer has been around. I think the change in approach is really the fact that we now think of oligometastatic patients as patients where local treatments can be added to the systemic treatment, which has always been the traditional treatment for patients with oligometastatic cancer. So again, systemic treatment we know has always been the mainstay of treatment for metastatic cancer. In oligometastatic patients, when they have limited metastatic disease, we now think about how can we use local treatments like radiation treatment, like SBRT, to help control the cancer even better.
Gene wants to know, when you say his PSA came way back down, what numbers were you referring to as way down?
Yeah, so his PSA came down to 0.07. So again, in someone who's had a prostatectomy, who's had their prostate taken out with prostate cancer, we really look to have that number be as close to 0 as possible. And when we were following Chester, his PSA at the time that we showed that first PET CT with that left clavicle lesion had increased up to about 1.37. So it was definitely way higher than we wanted. And with that being the only cited disease, the treatment allowed it to come way down.
And please explain PSA, and when
Sure.
should men start understanding and knowing more about that and getting it checked?
Yeah, absolutely. I mean, PSA is just prostate-specific antigen, so it's a marker on the surface of prostate cancer cells, and it's something that we can basically, in a blood test, be able to identify. And I think that many men should talk to their primary care doctors about getting their PSA checked, especially when they have a family history of prostate cancer.
What advancements have you seen in radiation oncology since you started practice?
So many. I mean, obviously, SBRT is kind of something that I'm very passionate about, so targeted radiation, but we have a lot of techniques that allow us to deliver radiation in a very, very targeted way. Proton therapy is something that allows us, again, to treat cancer in a way that really minimizes the dose to healthy tissues. And so, again, our technologies have really allowed us to treat patients better, treat them in ways that minimize side effects, and really do the best job in terms of controlling cancer.
Anything that's coming, advancing, that you're excited about?
Yeah, there are a lot of things on the horizon. I mean, it's really, I think the interplay of radiation treatment with other treatments like immunotherapy. I think a lot of us are excited about the idea that SBRT can maybe help even stimulate the immune system in fighting cancer in conjunction with immunotherapy. And again, it's really that interplay between radiation treatment and other systemic treatments, I think, that is on the forefront. There's something called SFRT, or spatially fractionated radiation treatment, and delivering radiation treatment in a very, very quick way, or flash therapy. So there's a lot of things that are on the horizon.
Well, what do you want people to take away today from this conversation for those watching and listening?
Yeah, I think just, again, being comfortable with having that open conversation with your physician, understanding that metastatic cancer is definitely not the end of the road, that we have newer and newer technologies that are coming out all the time, a lot of clinical trials that are available, and that really, with a good multidisciplinary team working together with the patient, there is really a lot of opportunities to continue to fight cancer and allow people to have a good, high quality of life while doing it.
Chester, again, thank you for being with us today. What do you want people to take away from your personal story?
Well, I want people to realize, like Dr. Reddy says, that a cancer diagnosis is not the end of the road, and I'm proof of that. Here I am 14 years later. So I just encourage people to get in, have their PSA checked as, maybe even younger, if it's in their family. But yeah, I feel very, very good about it.
Any encouraging words to men who may not feel comfortable talking about their health or may delay in getting to a doctor? What message might you have for them?
Well, they should get to a doctor. I don't know exactly what to say to them.
Yeah, well, like I said, you being here today, it just shows that it's okay to talk about it, and we appreciate you talking about it.
Oh, you bet.
Another question for you:
sure.
Do you sell those tomatoes?
No, I like, sorry, I like to just share with friends and neighbors and family, and and donate to food pantries and stuff like that. So.
Well, you're doing good work. You're doing good work,
Oh,
and good luck with your new
Thank you.
grandchild.
Thank you very much. I appreciate it.
Be well. Be well. Thank you so
All right.
much Thank you.
Oh.
Thanks to both of our guests for being with us today. Thanks to our viewers, and we will see you back here tomorrow. Coming up tomorrow on the Morning Medical Update, what looked like a cyst was really a tumor. I'm Jessica Lovell on the next Morning Medical Update. The rare diagnosis that paused this young athlete's football career, but only temporarily. Tuesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.